Usually when you hear about cancer statistics, there's this kind of grim, unavoidable mathematical logic to it, you know?
Right, like a direct correlation.
Exactly. If the global incidence of a disease goes up, the mortality rate goes up right alongside it. It's just basic cause and effect.
Which makes sense on paper.
Yeah. But if you look at the global data for kidney cancer over the last 10 years, that logic completely fractures. We are seeing this steady, undeniable rise in cases all over the world, and yet, paradoxically, fewer people are dying from it.
It's actually one of the most remarkable contradictions in modern oncology. I mean, you have this rising tide of diagnoses, but the actual lethality of the disease is being blunted, almost in real time.
And our mission for this deep dive is to figure out exactly how that is happening. We're looking at a massive stack of clinical protocols today, specifically the 2024 ESMO Clinical Practice Guideline for Renal Cell Carcinoma.
Yes, ESMO being the European Society for Medical Oncology.
Right. And our goal here is to take these incredibly dense technical guidelines and, well, translate them for you. We want to show you how the treatment of kidney...
Yes, the old flank pain, blood in the urine, and a palpable mass in the abdomen.
Exactly. And if you walked into a clinic with those three things, the tumor was usually already quite advanced. But the ESMO guidelines point out that this triad is practically history now. Today, the disease is almost entirely detected, incidentally.
Which is a huge piece of the puzzle regarding why the mortality is dropping. Because abdominal CT scans have become so routine in everyday medicine, we're catching these tumors incredibly early.
Just by accident, basically.
Yeah, exactly. Imagine you go into the ER after a minor fender bender just to get checked out, or maybe they're scanning you for suspected gallstones.
Right.
The scan just happens to pick up a small, completely asymptomatic mass on your kidney.
It makes you think of like a plumber who comes over to fix a leaky sink in your bathroom. While he's under the counter, he notices a completely unrelated, dangerously rusted pipe behind the wall.
That's a perfect analogy.
You had no idea it was there, but because he stumbled upon it, you get to fix the problem before the basement actually floods.
Right. And to push your plumber analogy a step further, sometimes we find pipes that are just a little bit rusted but aren't actually going to burst anytime soon.
So interesting.
Which brings us to how the pathology of the disease itself is evolving. Within that 90% of kidney cancers that are RCC, about 80% are a specific subtype called clear cell RCC.
Clear cell, because they literally look clear under a microscope.
Exactly. They are hoarding lipids and glycogen, basically fat and sugar, which just washes out during the staining process. But recently, the World Health Organization introduced 11 new molecular-driven subgroups.
11 new ones, that's a lot.
It is. We're talking about hyper-specific genetic classifications like ELOC mutated RCC or SMART-RCB1 deficient medullary RCC.
Those sound incredibly advanced. I mean, if you're a patient hearing that, you might assume we are customizing treatment down to the individual broken gene.
Right, it sounds like science fiction. And genome sequencing is undoubtedly the future of oncology. But what's fascinating here is that the reality in the clinic today requires a lot more pragmatism.
How?
Well, the ESMO guidelines are very explicit. Distinguishing the main clear cell subtype from the rest of the pack remains the absolute priority. The reason is that while identifying a specific, say, ELOC mutation on a cellular blueprint is scientifically interesting, many of these new genetic targets do not have actionable drugs attached to them yet.
Ah, I see. So the diagnostic science has outpaced the pharmacy.
Yeah.
We can name the specific genetic enemy, but we don't necessarily have a custom-built weapon to fight it.
Exactly.
Which brings us to what we actually do when we find one of these early localized tumors, like that slightly rusted pipe we found, incidentally. This is a space where the surgical philosophy has shifted dramatically toward, well, less is more.
It really has. Historically, if you had a tumor on your kidney, the standard approach was a radical nephrectomy. The surgeon simply removed the entire kidney.
Is it the whole thing out?
Yeah. But the data has shifted the standard of care entirely. For T1 tumors, which are those under 7 centimeters, the preferred option is now a partial nephrectomy. The goal is nephron sparing.
And just to clarify for everyone listening, a nephron is the tiny microscopic filter inside your kidney that actually cleans your blood.
Correct. You have about 1 million of them in each kidney. By removing just the tumor and leaving as much of the healthy kidney as possible, you preserve those nephrons.
Which protects their overall health.
Yes. It protects the patient's long-term cardiovascular and renal health.
And for even smaller tumors, the approach gets even less invasive, right?
Yeah.
The guidelines state that for small renal masses, so tumors under 4 centimeters, active surveillance is actually a recommended option
Yes.
because the data shows these tiny tumors only grow about 3 millimeters per year on average.
Yeah.
And the rate of progression to metastatic disease is a tiny 1 to 2%.
Exactly. We are finally recognizing that not every single cancer immediately threatens a patient's life, especially when you weigh it against the physical trauma and risks of surgery.
I have to pause here, though, because, well, the math makes total sense on paper. Imagine sitting in that clinic chair as a patient.
Right, the psychological aspect?
Yeah. The doctor looks you in the eye and says, "You have a cancerous tumor on your kidney. Our treatment plan is to wait and see." I mean, isn't that an absolutely terrifying concept for a patient to swallow?
Oh, it's incredibly daunting. Validating that fear is a massive part of a medical oncologist's job. But this is exactly why understanding the biological mechanics, like that 3 millimeters per year growth rate, is so vital to communicate.
It's about context.
Exactly. It's about reframing the threat level. When a doctor can show a patient that their specific tumor is essentially moving in slow motion and explain that jumping straight into surgery might cause immediate permanent harm to their kidney function, it changes the risk-reward calculation.
Yeah, that makes sense.
But it requires a very deep, trusting conversation to overcome that instinct to just cut it out immediately.
It's managing the psychology of the human being just as much as the biology of the disease. And speaking of the biology, here's where it gets really interesting. Most kidney cancers are sporadic, meaning they just happen by bad luck.
Right.
But there is a genetic condition called von Hippel-Lindau syndrome, or VHL. The guidelines highlight that about 70% of patients with VHL will develop multiple kidney cancers over the course of their lifetime.
And for those VHL patients, that old cut-it-out approach was devastating. Because their genetics caused them to form multiple tumors over time, they were subjected to repeated surgeries over the years.
That sounds brutal.
It was. They often eventually lost their kidney function entirely and ended up on dialysis. But the landscape for these patients has been completely upended by a new drug called belzutifan.
Belzutifan is a HIF-2 alpha inhibitor. And before we just throw that term around, let's break down what that actually means.
Sure.
To understand HIF-2 alpha, imagine the tumor is sending out a fake distress signal. It tricks the body into thinking it's suffocating and needs oxygen, so the body dutifully builds fresh new blood vessels right to the tumor to feed it.
Perfect way to describe it.
Belzutifan basically comes in and cuts the wire on that fake distress signal. And the trial data here is wild. In a phase 2 trial for VHL-associated kidney cancer, belzutifan achieved a 64% overall response rate.
64%.
It is delaying or completely avoiding the need for these patients to go under the knife multiple times.
It is a brilliant example of understanding the specific mechanism of a disease and building a drug to short-circuit it. It spares these patients the immense physical toll of constant surgical intervention.
So we've covered finding the tumor early and dealing with it locally. But what happens after a surgeon successfully removes a larger, high-risk, localized tumor? You kick the cancer out of the body, but how do you make sure microscopic pieces of it didn't get left behind?
Right, the recurrence risk.
Yeah, for decades, doctors tried to use older targeted therapies to prevent the cancer from returning. But the guidelines note those trials repeatedly failed.
They did. Giving a patient treatment after surgery to prevent recurrence is called adjuvant therapy. And for a long time in kidney cancer, trying to prevent that recurrence with targeted drugs like VEGFR inhibitors was like trying to stop a flood with a chain link fence.
Wait, let me stop you there. I want to make sure we don't get lost in the alphabet soup here. What exactly is a VEGFR inhibitor, and why was it acting like a chain link fence?
Good question. A VEGFR inhibitor is a drug designed to block the formation of new blood vessels, similar to what we just talked about with the distress signals.
Okay.
The problem in the adjuvant setting, right after surgery, is that any leftover microscopic cancer cells floating in the bloodstream aren't necessarily trying to build new blood vessels yet. They're often just dormant, hiding out.
Oh, I see.
So a drug that just blocks blood vessel growth passes right over them. It doesn't actually kill the hiding cells.
That makes total sense. You're targeting a process the dormant cells aren't even using yet. But that brings us to the massive breakthrough the ESMO guidelines focus on, which is the Keynote 564 trial. Now, the official recommendation is that patients with intermediate high or high-risk clear cell RCC should take an immunotherapy drug called pembrolizumab for up to a year after their surgery.
Yes. If we connect this to the bigger picture, the shift to immunotherapy in this setting changes everything. Pembrolizumab isn't a targeted blood vessel drug, it's an immune checkpoint inhibitor.
Okay.
Cancer cells survive by wearing a chemical disguise that essentially blindfolds your body's immune system, allowing the cancer to float right past your T cells unnoticed. Pembrolizumab pulls that blindfold off.
I like to think of it like home security. Surgery is like kicking a home invader out of your house. The immediate threat is neutralized. But because your house was targeted once, there's a risk they might return.
Yeah.
Using those older blood vessel drugs was like putting a slightly better lock on the front door. It might slow them down, but it didn't solve the vulnerability if they were already hiding in the basement.
Right.
Adjuvant pembrolizumab, however, is like hiring an elite security guard to actively patrol every inch of your property for a full year. It trains your own T cells to hunt down those microscopic invaders before they can take root and form a new tumor.
And we cannot overstate how massive this is clinically. Keynote 564 is the first trial to show not just a disease-free survival benefit, but an overall survival benefit in this adjuvant setting.
Meaning they actually live longer.
Yes, the patients receiving pembrolizumab actively lived longer than those who received a placebo.
But what happens if that microscopic security guard fails? What if those stray cells find a place to hide, multiply, and suddenly the cancer is no longer confined to the kidney?
Then we are dealing with metastatic disease.
Right. This transitions us into advanced or metastatic disease. And the first major paradigm shift here is that the old instinct to immediately perform surgery is practically gone.
Completely. Decades ago, even if the cancer had already spread to the lungs or the bones, doctors would perform an upfront cytoreductive nephrectomy, meaning they would still remove the primary tumor in the kidney, hoping it would somehow buy the patient time.
But that's changed.
Yes. A landmark trial called Carmina proved that for most metastatic patients, this upfront surgery does not improve survival compared to starting medication immediately. Systemic therapy is now the undisputed priority.
And the systemic therapies we have now are incredibly potent. First-line treatments are no longer just single drugs, they are heavy-hitting combinations. The guidelines recommend combining a PD-1 immune inhibitor with a targeted therapy, like lenvatinib plus pembrolizumab.
Or combining two different immunotherapies together, like ipilimumab plus nivolumab.
And what's the logic there?
The logic of these combinations is a 1-2 punch. If you combine a targeted drug with an immunotherapy, you are simultaneously choking off the tumor's blood supply while whooping the immune system into a frenzy to attack it. The results have just completely rewritten the prognosis for metastatic kidney cancer.
So what does this all mean? It means a diagnosis that a decade ago was considered rapidly terminal is actively becoming a chronic, manageable condition. The median overall survival for unselected advanced patients has now stretched past the 4-year mark. We're measuring survival in years, plural rather than months.
It's an incredible shift.
It really is. But if you're sitting there wondering how a doctor decides between all these confusing drug combinations, there's a fascinating controversy hidden inside these guidelines that is going to interest you.
Ah, yes. The debate over using the dual immunotherapy combination.
Exactly.
Using ipilimumab plus nivolumab in patients classified as having favorable risk disease.
The ESMO guidelines actually published the fact that there was a deep 70-30 split among the authors on this. 70% favored recommending this double immune combo for favorable risk patients, and 30% vehemently opposed it. Let's break down why. The 70% who favored it pointed to the fact that hitting the cancer with two different immunotherapies can induce durable complete responses. A complete response means the tumors essentially disappear from the radiological scans.
Right.
The trial showed a 13% complete response rate for the dual immunotherapy, compared to only 6% for the old standard drug.
And a complete response that lasts for years is the absolute zenith of oncology.
Yeah.
It is as close to a functional cure as we can possibly get in metastatic disease. The majority of the guideline authors argued that denying favorable risk patients the chance at that 13% total clearance was simply unacceptable.
But the 30% who opposed the recommendation had a very compelling counterargument grounded in the medical principle of do no harm. I really want to press on this because it highlights how agonizing clinical oncology is in the real world.
It really does.
The dissenting 30% pointed out two critical things. First, in this specific favorable risk subgroup, there was no proven overall survival benefit compared to the older, milder drugs. Second, ipilimumab one of the immunotherapies in that combo, is notorious for causing severe, sometimes lifelong immune-related toxicities.
Because when you take the brakes off the immune system that aggressively, sometimes it doesn't just attack the cancer, it can attack the patient's own healthy organs.
Wow.
Yeah, you can see severe inflammation of the colon, the liver, or permanent damage to the thyroid or pituitary glands, requiring lifelong hormone replacement.
So put yourself in that clinic room. Are we really supposed to risk a patient's otherwise healthy, functioning years with severe permanent organ toxicity just for a statistical 13% chance at a total cure? A favorable risk cancer might grow very slowly for years on a milder drug.
Right.
The doctor is basically asking the patient to sit at a roulette table. Do you take a highly toxic regimen for a small chance at total eradication, or do you take a milder drug that will control the disease but almost certainly never cure it?
It is arguably the most difficult conversation a medical oncologist will ever have. The fact that the world's leading experts split 70-30 on this shows that there is no mathematically perfect answer. It ultimately comes down to the individual patient's personal values, their age, and their own tolerance for risk.
It's a profound reminder that we treat human beings, not just clinical trial spreadsheets. But what happens when these incredible first-line combinations eventually stop working? Because the biology of cancer is relentless, and for most patients, the tumor will eventually mutate and find a way around the drugs.
Well, when the cancer progresses, we move to the second-line strategy. And the guidelines highlight a very important trial here called CONTACT-CO3. For a while, there was a working theory that if a patient's cancer figured out how to beat one immune checkpoint inhibitor, you could just give them a different immune checkpoint inhibitor to try and shock the immune system again.
Which makes intuitive sense.
It does. This is called ICI rechallenge.
But the CONTACT-03 trial proved that theory completely wrong. The trial showed that rechallenging the immune system with a new ICI does not improve survival at all. Worse, it drastically increases serious adverse events. 48% of patients experienced severe toxicities compared to 33% in the control group.
It is a vital lesson in drug sequencing. You cannot just hammer the immune system repeatedly and expect a different result. You just end up causing more collateral damage to the patient's body.
Think of it like having a master key that snaps off inside a lock. If you just grab a second identical key and try to jam it into the door, you aren't going to open it.
Right.
You're just going to cause permanent damage to the lock itself. You have to step back, realize the key mechanism is useless now, and grab a completely different tool like a crowbar to force the door.
And in this scenario, the preferred crowbar for second-line treatment is to pivot entirely away from the immune system and attack the blood vessels again. The ESMO guidelines recommend a VEGFR-targeted therapy called cabozantinib.
Oh, back to the blood vessels.
Exactly. The control arm of that same CONTACT-03 trial showed that cabozantinib provided a very robust, progression-free survival for these patients. It effectively starves the tumor of its blood supply when the immune system can no longer keep it in check.
And while all this complex systemic therapy is happening, patients are getting CT scans every 2 to 4 months. The doctors measure the physical size of the tumors using a universal language called RECIST criteria.
This raises an important question, though, about how we actually measure success. RECIST criteria measures the physical shrinkage or growth of the tumor down to the millimeter, but the ESMO guidelines explicitly pause to remind doctors of something critical.
What's that?
Clinical judgment of the patient in front of you is just as important as the math on the radiology report.
Which is fascinating because we tend to think of scans as the ultimate objective truth. But why might a scan be misleading when you're using immunotherapy?
Because immunotherapy causes inflammation. If the drug is working perfectly, your T cells swarm the tumor to attack it. On a CT scan, that swarm of immune cells and inflammation can actually make the tumor look bigger temporarily.
Oh, wow.
Yeah, this is called pseudoprogression.
Meaning, if the scan says the tumor grew by 3 millimeters, but the patient is sitting in front of you telling you their bone pain is completely gone, they are gaining their weight back, and they are playing in the yard with their grandkids again.
You don't necessarily rip them off the drug just because RECIST criteria says the mass is larger.
Right, you treat the patient, not the scan.
Precisely. RECIST is a tool, not a tyrant.
Looking back at the entire scope of the 2024 ESMO guidelines, the journey of renal cell carcinoma is nothing short of breathtaking. We started with a disease that was purely a blunt surgical problem. You cut the kidney out, and that was the absolute end of your medical options.
And now we're navigating an infinitely nuanced landscape.
We have nephron-sparing surgeries to protect long-term health. We have active surveillance for tiny tumors moving in slow motion. We have adjuvant immunotherapy, acting as a multi-year security guard against microscopic spread.
And we have complex multi-drug combinations extending metastatic survival into years rather than months. It is a testament to the sheer velocity of scientific progress. We are understanding the biological mechanisms of this disease at a level of granularity that was unimaginable 20 years ago.
But as we close out today, there is a lingering thought I want you, the listener, to mull over. We talked earlier about the World Health Organization defining 11 new, hyper-specific molecular subtypes of kidney cancer. We talked about how our drugs are evolving from single pills into highly complex, incredibly potent multi-drug regimens.
Right.
As genome sequencing becomes cheaper and standard across the world, we're inevitably going to identify the exact bespoke molecular key needed to unlock a cure for every single individual's specific tumor.
That is the goal.
But how are global healthcare systems going to adapt financially and logistically? Because providing customized, highly toxic, multi-year immune therapies to hundreds of thousands of individual people is a monumental logistical hurdle. We have practically solved the grim mathematical paradox of rising cases and falling mortality. But the new frontier is ensuring that the complexity of the cure doesn't break the system that provides it.
It is the defining operational challenge of the next era of oncology, translating the science into sustainable, accessible care.
It really is. The diagnostic landscape is no longer a simple black and white X-ray with a clean, broken line. It is murky, it is genetic, and it is infinitely complex. But as these ESMO guidelines prove, we are finally learning how to read the blueprints and, more importantly, how to fight back.